I think that we've really made a change in the past 5 years, and our expectations are now much higher than they were before. And we have to follow that dream to make people better. Everyone would like their disease to be cured. It doesn't happen very often in medicine where we actually take a disease and knock it out, never to be seen again. That's the goal for all things, but if we use another disease like diabetes as an example, it's more management of the ongoing problem rather than elimination of the problem. Same thing with rheumatoid arthritis. These medications, treatments, usually are long-term, if not lifelong treatments, and the goal would be to have those treatments be short-term, complete, reversing the underlying condition. If you will, to use the word cure. In other words, you had it yesterday, you don't have it any longer, it's not coming back. So far, we haven't come close to that. So one of the objectives would be to find treatments that are easier to tolerate, less costly, and short-term. We're not there yet. The other big area that so far hasn't had the breakthrough is osteoarthritis. In fact, more people have osteoarthritis than have rheumatoid arthritis. Far more people do. And the treatments there haven't changed as quickly as in other areas, mostly because it doesn't appear to be an immunologic disease. It appears to be a degenerative disease. So all of the biotech payoffs or breakthroughs that have come in the past few years haven't really helped osteoarthritis as much. That's coming. Now osteoarthritis, though it's more prevalent, probably is a less severe disease for most patients. Rheumatoid arthritis can be very devastating. In other words, if you look at the percent of people who have to go on disability and leave their job, it's much higher in the rheumatoid arthritis population than it is in the osteoarthritis population. So the impact on society is much greater. The age at which people get the disease, rheumatoid arthritis, is much lower than osteoarthritis. It doesn't mean that a 75-year-old doesn't want to feel better and do interesting things and even participate in athletics. But it's a less severe problem for a shorter duration in their life than it is for a 35-year-old to become severely ill. But osteoarthritis, I think, is the next large area that needs to be attacked. And so far, we're not much above where we were in about 1985 in that condition. There are some newer things, but they're short-term treatments. Joint replacement has been enormously helpful. It's odd that when rheumatologists were polled a few years ago, and then this is before the advent of new treatments for rheumatoid arthritis, what's the biggest, most important breakthrough in the treatment of arthritis in the past 25 years, they picked joint replacement surgery. Oddly enough, something they don't even do. And that's been fairly well perfected. In other words, the treatments nowadays are really refinements on an already successful group of surgical procedures. And more joints are being affected, but the hip and the knee, the place that's most commonly affected and it's most disabling, they're exceptionally good surgical treatments. And our patients do have that. It would be nice if we could identify it early and not get to the point of needing joint replacement surgery, but so far that hasn't come.
So normally you'll see a person and then the course of action will be joint replacement that you recommend for that person?
It depends on the condition. If someone has osteoarthritis, frankly, they don't want to have the surgery. It's a big undertaking. It's not terribly risky, but I think every patient worries about having any kind of surgical procedure of that magnitude, so they'd like to avoid that if possible. We'd like to have them avoid it if possible. But in the situation where it progresses or it's beginning to affect their ability to function in their lifestyle, then coordinating care with an orthopedist is it's done commonly. I'm in a fortunate situation where I work very closely with orthopedists. We basically work in the same office, so I see them every minute of the day. And it's common for us to see patients almost simultaneously, or for me to walk one of my patients down to their room, hopefully walk one of the patients down to the room, and try to introduce them to the next therapy that they'll need, namely surgical therapy, and make that transition easy for them so the surgeon can then assess the patient, decide what kind of procedure is appropriate for them, and have me then step to the background for a while until that procedure